Hi, everyone. Thank you for calling in. I can see the number of participants climbing here, which lets me know that we're live and people are joining. Thanks for calling into the Mind Matters seminar series here through the Addiction Center. It's right at 7 o'clock here in Ann Arbor, Michigan, and we'll give folks another minute or two to join, and then we'll go ahead and get started. While we're waiting, I guess I can provide just a little bit of background about the speaker series and what we're trying to accomplish. This is the second of a four-part series, and this is the first time we've offered this here at the Addiction Center. And our idea was to try and bridge the world of clinically applied research and the delivery of clinical services. As you may know, U of M has a really substantial research portfolio and a large medical system, but sometimes it can feel like those worlds are not fully connected to each other. And we sometimes hear from patients that they wonder how are we using the research that's being done here to inform the care that we deliver. So in a lot of ways, in response to that feedback, we designed this seminar series as a way to talk about some of the foundational research that goes into our thinking about what we mean when we talk about addiction and how we think about treating addiction. So as I mentioned, this is a kind of a first for us. We're hoping that this is useful to the general community, to patients, to families, and we hope that you find it useful. Please provide feedback, because that's why we're doing this, is to be helpful, and we really would love to hear from you about whether this is valuable or not. So you'll see multiple ways to contact us that appear in the chat throughout this presentation, and please take us up on the opportunity to let us know if this is useful. Okay, it is a few minutes after the hour. I think we'll go ahead and get started. As I mentioned, this is the Mind Matters seminar series here through the Addiction Center, and I'm Mark Ilgen. I'm a professor in the Department of Psychiatry, as well as the director of the University of Michigan Addiction Treatment Services, or as we call it, UMATS. UMATS is located in the Rachel Upjohn building off Plymouth Road here in Ann Arbor, and it's been a part of the Addiction Center and the Department of Psychiatry for close to 15 years now. A core part of our mission at UMATS is to deliver care that's directly informed by research. And as I mentioned before, our goal in this seminar series is to try and explain how that research informs the care that we provide. And this seminar series has four components. The last one that occurred last month was talking about biological models for addiction and how we understand the phenomena of addiction. And this session will be about psychosocial treatments or behavioral treatments for addiction, and how we approach those, how they might work, and for whom they might be particularly beneficial. And then next month, we'll be focusing on medications and the role of medications in treating substance use disorders. For tonight, we're joined by Dr. Ann Fernandez. She is an assistant professor in the Department of Psychiatry and the director of clinical programming at UMATS, and as well as a participant in the multidisciplinary alcohol-related liver disease clinic at the University of Michigan. Dr. Fernandez is a practicing clinical psychologist in both clinics, and her areas of expertise include substance use and health psychology, with a current portfolio of research focused on optimizing surgical outcomes for individuals with alcohol use disorders, how you structure pain management and care for individuals following surgery. Dr. Fernandez received her doctoral degree in clinical psychology from the University of Rhode Island with a focus on health psychology. And she completed her clinical psychology residency in behavioral medicine at Yale New Haven Hospital and her postdoctoral fellowship at the Center for Alcohol and Addictions Studies at Brown University. Dr. Fernandez, thanks so much for joining us. Before we begin, I want to just mention a couple of housekeeping items. We're really encouraging people to use the Q&A function on Zoom instead of the chat. There's a way to submit questions anonymously, and you can submit them throughout the presentation. We'll go ahead and hear all of Dr. Fernandez's presentation, and then make sure we leave about 20 to 25 minutes at the end to go through questions. And please don't hesitate to put those in, because I think the discussion will be much more engaging and robust if we're focused on your questions. Also, a recording will be available and emailed to everyone as soon as it's available following this session. Now let's go ahead and begin. Dr. Fernandez.
Thank you so much, Dr. Ilgen, for the introduction, and thank you for having me in the Mind Matters series, and for everyone who's here showing interest and who has interest in this topic and whose lives have been impacted by addiction or substance use disorders. Whatever brings you here today, we're really glad you're here. So I am going to go ahead and share my slides, so bear with me for just one moment. Okay, so hopefully that's showing up properly for everybody. So as Dr. Ilgen said, I am assistant professor at, in the psychiatry department at University of Michigan. I'm a practicing clinical psychologist in 2 addiction clinics, and also do research in these areas, which is largely behavioral in nature, either identifying people with addiction within the health system or trying to develop and improve treatments for addiction. Today's learning objectives. So today we're focused on treatments for addiction, which are behavioral in nature. So I'm going to start with the history of addiction treatment models in the United States to give some context for why we have the treatments that we have today. I'm hoping you'll gain knowledge of current prevailing behavioral addiction treatments, understand how treatment recommendations are made, talk about some of the services we have in our clinic, the University of Michigan Addiction Treatment Service, answer some frequently asked questions, and then take questions from everyone. So just a brief sweeping history of addiction treatment and addiction models. And when I say model, I'm referring to people's understanding of what addiction is. The way that we understand addiction in our country or in our society is really important to understand what treatment or approach we have to dealing with it. So, for example, the prevailing belief around addiction in the early 1900s and late 1800s was coming from a moral model, that addiction was really a moral weakness. So not kind of our beliefs today around loss of control, genetics, biology, environment, and learning, but really coming from this idea of morality. And it's a moral failing. Treatment was often punishment-based. People could be institutionalized, even sterilized, for having addictive issues. And church and religion were also often seen as a way to seek treatment. And some institutes that did treat addiction kind of in the mid 1800s started to get closed down in the early 1900s as this kind of really moral model started to take over. In the later 1900s, the federal government got involved in the regulation of narcotics and prescribers for really the first time. If you think back to the like medicine man idea, you know, of cocaine-based elixirs and morphine and medicines, you can kind of see this unregulated area. But sort of in the earlier 1900s, addiction or addictive substances started to be regulated by the government. There was actually the first morphine maintenance, so early medication-assisted treatments. Clinics opened in the early 1900s, and then the federal government actually closed them. Prohibition, which everyone usually knows about, for alcohol was enacted in 1920, rather unsuccessfully. And then 1938 marked the beginning of federal involvement in addiction research and treatment. So partially in response to, I think, the sweeping moral model and probably the failings of that as an addiction treatment philosophy, I think, really opened a void for a different understanding of addiction and a more compassionate and holistic treatment approach. And in that context, Alcoholics Anonymous, which is, I still think, probably the most well-known addiction treatment available in this country, was developed by Bill W. and Dr. Bob when they met in 1935 and published the Blue Book in 1939. And the big difference with this model was that they didn't see alcohol problems as a disease, as a moral weakness. They saw it as a biological disease. So that was a really big shift. It wasn't just, they weren't the only ones who had this idea, but this was kind of when it really got heralded into the broader public. And the core belief in that was that this biological disease was like an allergy. You were an alcoholic or you weren't. You responded to alcohol in a certain way. And that recovery involved a spiritual cure and also abstinence from those substances. And the empirical basis was really lived experience and personal observation. In the 70s, throughout a lot of the mid-century, a lot of the 12-step movements really grew. And in the 70s, there were institutes within the NIH, National Institute of Health, that were developed to address alcohol and drug use on a research and scientific scale. So in the 70s, things started to really change with addiction treatment. So studying the epidemiology of substance use, including there's a really large study that's been going on through this institute. There's Monitoring the Future and other longitudinal studies. There was a big growth in behavioral research and a cognitive revolution where we kind of understood started to study how people think, understand, and conceptualize, and how that relates to addiction and addictive behavior. And really applying more research on perceptions, on motivation, on learning and environment and social aspects, and how do these impact addiction and contribute to addiction, and how we treat it. And so some of the treatment paradigms that started to emerge from that were concepts like harm reduction, or the idea that we could potentially reduce use, or not only reduce use, but reduce harm associated with addictive substances. Now we think of needle exchanges, but this could also be a really broad range of approaches, including helping someone with their finances when they're struggling with addiction to try to stabilize them or stabilize their housing. There was also relapse prevention, which was more of a cognitive behavioral model, and motivational interviewing. And I'll talk a little bit more about those types of treatments in a little bit. And what also got set up, and still persists to this day, is a bit of a tension between research-based treatments and research-developed treatments and some traditional addiction treatments, which sometimes are at odds, but I think often complement each other. So a little more about some of the current behavioral addiction treatments that are popular in this country and that are available throughout the nation include various types of behavioral treatments. And just to define what I mean when I say behavioral treatments, this is really an umbrella term, which is referring to different types of therapies that treat both mental and behavioral health disorders, seeking to identify and help change self-destructive or unhealthy behaviors, usually involving an individual or group therapy and multiple sessions over time. And so not medication-based treatments, but talk therapy, would be an example of this, and the different types of therapy that encompasses. So cognitive behavioral therapy is probably one of the most well-known therapies which can be applied to addiction, but is often applied also to other mental health problems like depression and anxiety. And in its inception, it was for broader mental health difficulties. And the background of the development came out of behavioral and cognitive treatment and understandings of social learning theory, where Aaron Beck had developed this triangle where we see this interplay between thoughts, behavior, and emotions, and how those three things interact with one another impacts what our mental health picture or our addiction picture is like. So essentially, the goal is to, or it grew out of this idea that our maladaptive thought patterns and behavior patterns are contributing to mental health difficulties or addiction. And in trying to understand those things and unpack them, we can essentially unspiral some of those behaviors and maladaptive thinking patterns. So some of the things that happen in cognitive behavioral treatment are a lot of raising awareness of how a person thinks, how they're acting, and what their emotional patterns are, and helping people to identify what, so for example, in an addiction context, this would look like helping someone identify what's triggering them to use substances, what context, what environments, what people, what are the events that lead up to it, and then also how they're thinking and making choices, how much they're using and when, and how they feel immediately after, and also long-term. I'm trying to help people understand that and then gain skills in avoiding either risky situations, thought patterns, or helping them cope with emotions in ways that don't involve substances. And cognitive behavioral therapy is has some of the strongest research support of any treatment for addiction, as well as for other types of mental health difficulties. And the idea is these are often 12 to 16 session protocols, and the skills that you build and the insights that you draw from these should last long after treatment. So another type of addiction treatment that people often don't know about, but interestingly is probably one of the most research supported approaches to addiction treatment, is called contingency management. And the idea behind contingency management is really about behavior modification through reward. So contingency management based interventions provide rewards to reinforce positive behaviors, which may be abstinence or might be treatment attendance for addiction, and also increase treatment retention and promote abstinence when studied in research. So often in these protocols, if you may blow into a breathalyzer for an abstinence verification, or you may go to a treatment and check in there, and you would get a small reward. And that small reward is a small positive reinforcer that makes you more likely to repeat that behavior again. And often these rewards will grow in size with increasing numbers of days abstinent or increasing numbers of engaging in treatment. So the reinforcers get larger, and sometimes there's small consequences for breaking a streak. So you're reinforced to continue with that positive pattern. And these treatments are actually surprisingly effective. They're often paired with other treatments. So they can be used in isolation, and they have been studied in that way, but they can also be paired with other behavioral type treatments. So there are kind of two types of ways this might play out. So there's both voucher-based reinforcement system, where a patient may receive a voucher for a desired behavior. So if this happens in a clinic, they could then use that exchange it for movie passes or gift cards. The idea being that in some treatment programs, they would not want to give cash money because that could be used to buy substances, for example, which would be the opposite of what we're trying to reinforce. And then there's also prize-based reinforcements where patients receive prize draws from a bowl. And there's a randomness to that, which can also actually play into reinforcement patterns in research, is, the desire to get a large versus small reward, and how that may incentivize, the randomness can incentivize the desired behavior as well. And as I said, these are often combined with other treatments, like you go to example for an intensive outpatient program, and then you also get to draw from a fishbowl every time you go there. So you're getting two treatments in one, essentially. And interestingly, a lot of these treatments, the contingency management in particular, is probably one of the more underutilized treatments that's available, considering the research evidence of how effective it can be. And some of that has to do, I think, with inclinations towards how people may feel about reinforcing someone around an addictive behavior, even if it's for abstinence from that behavior. So addiction, unfortunately, is still highly stigmatized. And so I think sometimes large scale institutions, states, insurance carriers, this isn't always the first thing they want to invest in, is giving money to someone for not using a substance, which is a broader discussion probably for another time of, whether that's appropriate or not, given the research evidence for this approach. But that is part of the treatment landscape at this time. So another really important treatment approach that has come into the forefront over the last probably 20, 30 years is motivational interviewing or motivational enhancement-based treatments. And this kind of grew out of the rather sometimes confrontational approach to addiction treatment that had prevailed for some time, I think, where this idea that someone has to hit rock bottom, you have to break through their defensiveness, you have to really confront someone with an addiction because they're never going to see it, they're in denial, and these really kind of dogmatic ideas around addiction that had taken root and had kind of grown into a lot of treatments were really unappealing to someone who may be experiencing some addictive behavior, or maybe they're not sure if they have an addiction, they want to find out, and they don't necessarily want to experience a very kind of denial-busting confrontational treatment. So Bill Miller developed this starting in the 1980s as sort of the antithesis of that approach, which is it's a very person-centered approach that approaches ambivalence. So if someone is exploring their substance use, trying to figure out if they want to change, it really uses the person's own ambivalence, reflects back to them how they see and understand their own addiction through really careful crafting of language, where you use a lot of open-ended questions, a lot of affirmations. So, surprisingly the opposite, positive statements about the person, their abilities and capabilities. It emphasizes autonomy of the individual to both change and make the decision to change. And it can also be used to help people engage in treatment by kind of trying to help them resolve their ambivalence, move through that, and then make a commitment to a healthy change, whatever that ends up being for them. It's really collaborative and compassionate style that's trying to pull what we call change talk out of people through conversation. Typically, this is a brief course of treatment that is given to people often when they're trying to decide if they want to change or not. So it can be done in a group or one-on-one, but it can be really effective and is a really important, I think, area of addiction treatment that didn't really exist before, which is a treatment that meets someone where they are. Even if they're not quite ready to change, they can still get a treatment approach that could help them, if that makes sense. So in addition to those treatments that I described, there are still many, many widely available mutual help groups. And as I described, when AA started in the 30s, it's grown to a huge international organization, and now also has research associated with it that shows that it can be an effective addiction treatment as well, although it's a peer-based treatment. It's free and available in the community, as opposed to those other treatments I described, which would take place in a clinical setting. And mutual aid organizations that are available now include Alcoholics Anonymous, Narcotics Anonymous. There's also some more secular alternatives. So AA and NA rely on a little bit more of that Judeo-Christian belief system of a higher power, and some people find that a bit off-putting, or other things about the program don't kind of mesh with their understanding of themselves or with addiction. So there's also an organization called Smart Recovery that's also a free mutual aid society that's both online and has in-person groups, and uses a little bit more of a cognitive behavioral approach to addiction, including having people meet, set goals, understand their triggers, and change their lives through engagement with this organization and through some of those skills that they build. And I think one of the really wonderful things about mutual help organizations is that they are available almost any time, any place, especially now with the virtual world and so much of them available online, that there's no cost associated with them. And they're so readily available that that they're really an integral part of treatment for people, but not necessarily an absolute critical part of treatment for everyone. I think sometimes is even in my work, I've seen sometimes a belief that AA or NA, if you're not doing it, you're not really in recovery, which isn't really a model that I adhere to. But with that said, I think that there is an incredible benefit when these programs work for people. It's free, it's readily available, it's everywhere. It connects you with peers and sponsors and people you can call. That's something that really no other treatment can offer. So it's a pretty incredible program for people who get involved and benefit from it. So that kind of summarizes a bit about different types of treatments. There are other types of treatments, of course, and people are welcome to ask questions about those, and we can discuss other things that might be available. But I wanted to take a minute to talk a bit about levels of care. So addiction treatment is sort of the type of treatment that you may get, the philosophy, the skills, the type of things you may learn or be asked to do. But there's another element of addiction care, which I think is also really important to understand, which is called level of care. So really briefly, levels of care include a continuum of addiction services that are available to people in this country. And they range from, there's a numeric scale, this is from the ASAM criteria, American Society of Addiction Medicine. And it ranges from an early intervention, so the lowest intensity intervention is the early intervention, which would be more like a preventative service, either before an addiction develops or before a severe addiction or substance use disorder develops. So kind of a lower touch preventative treatment, which then increases to outpatient services. Outpatient services would refer to individual or group therapy that meets for an hour or maybe a few hours a week, and then increases to intensive outpatient, which is usually an intensive outpatient program for substance use disorders. Typically is 3 days a week for a half day for a month. So if you think of 4 weeks, Monday, Wednesday, Friday, half day for that month. Or even partial hospitalization services, which is more like a full day program for a certain amount of time. That increases to residential or inpatient services where someone is actually staying somewhere, spending the night there, and adding to the complexity, people who have more complex addiction needs, there's also medically managed inpatient or intensive services at the higher and highest levels of care. And so you may wonder, like, how do we determine who goes to what level of care and who makes that determination? Is it a patient? Is it a clinician? And it's both patient and clinician essentially, but so anytime a level of care is being recommended, I don't want to use the word assigned because the patient is very much a part of this decision-making process, but a clinician will recommend a certain level of care. So often what happens when someone comes into a substance use disorder or addiction treatment clinic for the first time is they will have an evaluation. So not just jump into treatment, but the first step is getting an evaluation of what's going on, making sure the level of care and the type of treatment is matched to the patient's needs. So There are 6 dimensions in that evaluation that determine what level of care is appropriate for a given individual. So the first one is acute intoxication or withdrawal potential. So exploring an individual's past and current experience with substance use and withdrawal. So are they at risk of using currently, and are they at risk of withdrawal if they stop? So alcohol withdrawal, for example, can be fatal. So it's really important to take into account these kind of factors when assessing someone and making recommendations for their care. So second dimension, I should say an unsupervised alcohol withdrawal. If someone has a high risk for withdrawal, they would go into a medically managed program and they can withdraw safely with medical supervision and care. The second dimension would be biomedical conditions and complications. So if the person has a complicated health picture overall and physical condition may be good or bad, would determine treatment placement recommendations, as well as dimension 3, which is emotional, behavioral, or cognitive conditions or complications that may impact what type of treatment program they may get placed in. That could even include things like having a co-occurring anxiety or depression problem, or other kind of disorder where they could even be referred to like a dual diagnosis program, which could treat both addiction and other mental health problems at the same time, which there are programs like that in the state. There's also readiness to change. So is the person ready and willing to go to treatment? That's a really important thing to assess as well as relapse, continued use, or oops, my video is blocking this, so I can't see it. So yes, exploring their unique relationship with substances as well as their continued use of the problem. So their risk of relapse, their history of relapse, or how likely they are continuing to use it at a given time. And then also what their recovery or living environment is. So really knowing, where is someone living? Are they in an environment that's supportive of recovery? Are they in an environment where everyone in their home is using substances and they can't get away from it? So some of those things will determine the level of care and placement and intensity of treatment that might be recommended when someone comes in to a clinic. And then in terms of picking what is best, so as I mentioned, a clinician will make a treatment recommendation, but of course the patient that has to be something that will fit with the patient's life and lifestyle at that time. And often we'll work with patients. Sometimes if there's a disagreement about what may be appropriate or possible, sometimes we'll work with the patient to try to find a better time for like an inpatient treatment, for example, if there needs to be a little bit of a waiting period, or sometimes working on an outpatient level, it makes more sense for a patient at a given time, or maybe they're just not ready to engage in any intensive care. And so we might do more of the motivational interviewing approach that I mentioned to try to keep the person engaged and continue to work with them until maybe they get to a place where they're more ready. So I think a first step in these conversations is really just an open and honest exploration of what the patient needs and wants. After a clinician will, provide what they recommend based on the assessment, and then it becomes a conversation sometimes with the patient and the family around next steps. And sometimes it does require trial and error to find out what works best. Clinicians aren't magicians. We don't know the future and what's exactly right for a person. So sometimes we might try outpatient treatment with someone and they really struggle to maintain abstinence. And then we'll say, you know what, I think potentially a 30-day residential stay might be best for you if you really want to maintain abstinence, for example. So Addiction Treatment Service, the clinic that we have at University of Michigan, just to briefly go over some of the services that we offer and how they fit into what I've presented about. So we offer outpatient addiction care for adults and adolescents. So kind of talking about those levels of care I mentioned, this is levels 1 to 2.1 on that scale. So that includes addiction assessment and consultation, individual behavioral treatment, including cognitive behavioral therapy and motivational interviewing based treatments. We have encouragement and support related to linking people with mutual help groups like 12-step, and just trying to facilitate that. We've even had some peers in our programs before to link to that. We have group therapy. We have addiction psychiatry and addiction medicine, and residents who do prescribing for medication-based treatments or medication for opioid and alcohol use disorders, and also for psychiatric medications when people have co-occurring depression and anxiety and other difficulties that they need medication for, as well as dual diagnosis treatment for people who have addiction as well as another mental health diagnosis. And in terms of who can come to UMATS, we welcome all people and want to understand and change their substance abuse, even people who aren't necessarily ready for change. We do have groups that are designed to kind of help people in that early stage to unwind some of their ambivalence around change. Adolescents through older adults, and we accept most major private insurance and Medicare. For the group treatments we offer individual therapy. We also have quite a few groups. We have, during COVID with the virtual programs, we have an intensive virtual program. It's not quite an intensive outpatient program. It doesn't quite meet the definition, but it is an intensive program in the sense that it meets 3 days a week, 1.5 hours a day for 4 weeks. We have weekly groups that meet for an hour or hour and a half, including a cognitive behavioral therapy group, a discovery group that uses motivational interviewing, and a dual diagnosis group, as well as we have a group for family and friends of those who have substance use disorders. Our nicotine cessation group is actually paused right now, but we just recently started one. We have early recovery groups, adolescent recovery groups, and a support group for people who take medications for opioid use disorder. So I do have some frequently asked questions. I'm just about out of time, but there's only a couple, so I may just answer them quickly because I think they're important things to touch on. So a really common question that I get asked is about whether treatment works. And so if others have questions around that, we can talk about it in more detail, but I would say that not all treatment works. So not every single type of treatment that's out there is necessarily effective. There are actually quite a lot of treatment programs that are quite financially motivated and offer sometimes less than effective treatment programs. The NIAAA has a treatment navigator that links people to evidence-based or reliable programs. So I always recommend people look on there if they're looking for treatments. There's also treatments that have been offered in the past that the evidence-based has shown they don't work, like some of the, there were like shock treatments. If you drank, you'd get an electric shock for extinction of addiction behavior. That showed that, for a week that would work, that people would slowly start using again once that treatment ended. So not all treatments work, but there are some, or many, many treatments that do, including the ones that I presented today. And it appears to work better if you're receiving it and if you continue care, not surprisingly. Is treatment necessary? So there are definitely people who change their substance use without treatment, but it does become more difficult with increasing severity of addiction, just because of the biological changes that happen at the level of the brain and the triggers in the environment that persist even after someone may stop using. They're still at risk of relapse, and that can be hard sometimes without support. Residential treatment is not necessarily more effective than outpatient treatment, to the surprise of some. It does depend a bit on the individual and what they need. So just a few other questions. Are medications effective to treat addiction? Yes, they are, and that's actually the topic of our next talk. They're often most effective when coupled with behavioral treatment. So the two go together to be the most effective package. And Are some people a better fit with specific types of treatment? I would say yes. And sometimes a clinician can help someone navigate that and teach them about the menu of treatment options. And then some of it, of course, is trial and error. And with there, I'm just going to stop sharing so that we can start taking some questions. And thank you for listening, everyone.
Wonderful. Thanks, Anne. And we'll go ahead and ask a few questions. As a reminder, please feel free to use the Q&A function that is part of this seminar. You can post questions anonymously if you wish to do so. And we'll do our best to get through all those tonight. So I guess my first question is really geared towards thinking about how to help a friend or loved one. So if you have someone you care about who you think might benefit from thinking about or engaging in addiction treatment, do you have any recommendations for ways to approach that individual and suggest that they reach out for care?
Yeah, that's a really good question. And one that definitely comes up a lot. I think that people are often hesitant to bring up these topics with their loved ones because it is very uncomfortable and can be something that isn't always talked about in the normal course of daily conversation. But I think it's really important that people realize that it is okay to talk to their loved ones about addiction, just like you would with other health conditions that you might be concerned about with a loved one. And what I would recommend if you are approaching someone is to come with a plan. I would think about what you're going to say to someone before you bring it up. And also, maybe even write down what you want to say, practice what you want to say, and come at it, most importantly, from a compassionate, helpful stance. And the term that I like to use is loving concern. So express loving concern for a person. And if you have one, you could make a really specific request or recommendation for what you think they might do. If you feel comfortable with that, or you could open up a conversation and the person may discuss it with you as well. There's been traditionally, I think a lot of people are aware of the intervention approach to kind of ambushing someone. Sometimes historically that could include like putting them in a car and taking them to an addiction treatment somewhat against their will. I don't necessarily recommend that, and the evidence kind of bears out that that's not necessarily the best approach to take, but to approach someone compassionately, talk with them, make recommendations is all totally appropriate when you see someone struggling with something that they may not be even fully aware of themselves. And continuing to have those conversations with those people, especially if it's someone in your life who may be caring for your family members, may be responsible for safely driving people around. It's important and sometimes critical to have those conversations for the person's own safety as well as the family's safety. So I would really encourage people to do that.
Great, thanks. And there is actually a question coming up about UMATS Friends and Family Group and whether, so I guess for more context for people, that we do have a group for friends and family of individuals with substance use disorders, and that's open to people whether or not their loved one is in care or not. So we can, so they can attend that, and that can also provide some support in this process.
Yeah.
One of the things I was wondering was when you talked about treatment itself and these different forms of treatment, how much do patients need to have a formulation of what their treatment should look like when they show up to care? Is that something where you expect someone to come in and really advocate for a specific type of treatment, or is that something that comes out of the interaction there?
Yeah, that's a good question. I think it depends a little on the patient, but I will say as a rule, I don't necessarily expect a patient to have an understanding of the addiction treatment world and what happens within it. I find it's a little bit sometimes of a black box until someone has been in the treatment, been in treatment and experienced it, kind of what may or may not happen, and also what level of care may be available. And so I often find people come in, at least in my experience, most often, is it's a little more on the clinician to educate the patient about what different options may be out there, and then help the person kind of navigate that. But with that being said, there are many people who sometimes have been through a lot of addiction treatment before and might have a really good understanding of what they want and need, and that's totally appropriate. I think once in a while we will get someone who's like, I want this really particular type of therapy. That's what I'm looking for. Do you have someone that does that? And that's great, and the clinician can say whether the treatment clinic has it. They could make a referral to one that does, or maybe if they think that something else might be appropriate, they would have that conversation with you. So I think either is fine. You don't have to know anything to come to treatment, but if you do have a strong preference, then make that known.
Great. And one of the questions here is asking about the success rate and the perception that addiction treatment programs have a low success rate, and then whether U of M's program, how we compare to those overall success rates. So can you talk a little bit about just on average, how successful is treatment? Should people be optimistic when they show up? And then how might U of M look similar or different to what's out there?
Yeah, so I saw a statistic recently that 70% of people eventually, and it may not be the first try, addiction is a chronic and relapsing condition, but with multiple attempts, eventually about 70% of people will reach durable sobriety or long-term sobriety for a period of time. And I think that, when you look across someone's life course, it may take 4 attempts to get to that place, depending on the severity of their addiction, especially, but that eventually people can get there. And I will say that a lot of times people, and when we do a short-term research study, for example, a lot of treatments, if they have a 30% success rate, are considered to be a good treatment, believe it or not. And that's partially because of shorter term follow-ups. We're not looking at multiple attempts over time. So when we look at people over the life course, it's the majority of people that overcome addiction. So I think people should be really optimistic, but also be quite realistic about the likelihood of success after one treatment attempt, or the likelihood of success with never having a relapse. That might be a little less likely, but eventual long-term sobriety is something that's very achievable. And so people should feel encouraged by that and to keep trying, even if they have slips. We see people in our clinic all the time. We see them, they have 3 months of sobriety, they may have a relapse, then they come back, they get back on their feet. We've had amazing success. We try to end our meetings with positive stories of people who've really achieved things like that, because it's really wonderful and it does happen. In terms of the UMATS success rate, that is a really difficult question to answer, and partially because there really isn't data to compare it to. So, for example, most treatment programs are not keeping track of people longitudinally, calling them every 6 months to a year and assessing if they're still sober or abstinent, or if they've reduced use. And even if they did, they're not sharing it. So we can't really say, we're achieving X success and here's how we compare to other treatment programs. So I wish I had an answer to that question. And I think any website you see for a treatment program that's claiming that they have a success rate of 80% or even 70%, I would be really skeptical about that and wonder where those numbers are coming from and also, what they're comparing to.
Yeah, one truism is that the people who tend to stay in touch or in close contact with their treatment program tend to be the people who are doing well. And so programs will sometimes have 100% success in the people who are still talking to them 2 or 3 years later, but that doesn't necessarily mean that that's the impact of the intervention. There was a question in the chat about specifically about the CBT results that you presented, mentioning that the follow-up rate for those studies, or the follow-up interval for those studies, so how long people participated, usually was in the 6 to 12 month range. Do you know of research looking at longer term outcomes with CBT for substance use disorders and the extent to which those work over the long haul?
Yeah, it's a good question. I think part of the limitation is the difficulty of retaining people in research studies for really long periods of time. So, as someone who has run some addiction treatment clinical trials, I'm keenly aware of the feasibility challenges of following someone for more than a year, or following a group of people to study them for more than a year. There's been several really large studies that have been conducted that looked at various addiction treatments over longer periods of time. Project Match is one. Mark, do you know how long was their follow-up? Do you know off the top
They
of your
had,
head?
sorry, I couldn't find the mute button there. Yeah,
Okay.
so they went, they had a 12-month follow-up, and then they had a 3-year follow-up.
They did
after that. Yeah.
So there have been a few large studies. If you wanted to look up, Project Match is one of the big ones, and what the conclusion largely of that study, they were trying to sort of do a little bit of a horse race with that study to figure out which type of addiction treatment may be best behavioral treatments. But what they actually ended up finding was that engaging in treatment was predictive of success regardless of the type of treatment. And these were all well-controlled, well-developed treatments that were considered to be effective, but they didn't find one was particularly better than the other. So a more CBT-based treatment was effective over time, but and so was like a 12-step facilitation type treatment that linked you to 12-step and helped you kind of work through that treatment, for example.
Great. And there are a couple of questions in the chat that are in the Q&A that I can just answer quickly about in-person versus telephone-based services, and just what is currently offered at UMATS. What are we doing? For UMATS, we offer the option of either in-person or telehealth assessments and interventions individually right now. When it comes to groups, all of our groups are now only on telehealth platforms, and that's in part because of the challenges of mixing live in-person people with telehealth. And all of this is really in a state of flux. It's looked different month to month over the past 2 years. But we're optimistic that we can go back to in-person groups again soon. But if someone is interested in services and particularly focused on seeing someone in person, that is possible to do now. It's just that the groups themselves are offered via telehealth.
Yeah, we have individual therapists that do see in person, and prescribers that see individuals in person as well, just not the groups.
Mm-hmm. And we're almost to the end of the hour here, but one other question to ask, and the Q&A here is just a little bit more about when do you feel like someone is in either durable or long-term sobriety? What sort of length of time does it take to really feel like someone is turning this around and it feels like it's sticking?
Yeah, that's a question that I hear a lot, and it's a really good question. So the answer, I'm going to answer this a couple different ways. So the research that has been done, to give you a black and white answer, is that 5 years is usually the length at which, if someone reaches sobriety for 5 years, they're really unlikely to relapse. So that's been a bit of a cut point that has been established. However, it's not binary. So what we know is that relapse is by far most common in the months just after a person stops using a substance, and 6 months it decreases, a year the likelihood of relapse decreases, and over time that continues to decrease. And something else I will mention just in answering that question is I think that we often undervalue periods of sobriety. So even a period of sobriety that may then have a relapse happen is still very valuable for health, for physical health and for mental health, and also has a huge amount of learning that happens during it that a person can apply if they stop using a substance again. So I guess I would also just like to have that caveat of, even if someone doesn't reach durable sobriety, they learn something every time and they can get back on the horse and keep going and learn from every slip that they have. So it may be 5 years from someone, but other people, it may take a few tries.
Yeah, I think that's an excellent point. And we really do see that pattern where the slips get shorter and shorter over time. And it's because people are getting better at turning it around quickly.
Yeah.
Wonderful. Well, we are pretty much at the hour. We hope that everyone who called in found this helpful. Thank you, Dr. Fernandez, for your comments and for all the slides on research on addiction treatment. We provide a couple links in the chat, and those also include links to the next 2 sessions that we'll be offering there in April and in May. I want to make sure that I note and thank the Patrick Gibbons Memorial Fund, which has provided support for this educational series. And as I mentioned, please reach out to us if you have topics you'd like to see covered or specific questions. We're very eager to get input on how we can make this more impactful. Thank you so much for attending, and we hope to see you again next month. Take care.